This is Dr. Priyadarshini, your course director of study EBCOG at StudyMEDIC. And today in this RRR series, we are going to discuss on the module labor and delivery. Starting with a quote, success is a journey and not a destination. And I'm sure this video will help you to prepare better for your exams. So let's start with some questions. We are basically going to deal with how we are going to approach your SPAs and EMQ for the upcoming EBCOG Part 1 exams. So here we have a question. We have a 27-year-old primary gravida at 40 weeks and 3 days in active labor. She's been on continuous CTG monitoring due to meconium stain liquor. The CTG shows a baseline of 175, reduced variability for 40 minutes, no accelerations, and late decelerations are present for the past 25 minutes. She's 7 centimeter dilated. Contractions are 5 in 10 minutes. The fetal blood sample is 7.18. What is the appropriate next step? So what are the necessary information you need to pick up from this? One is primary gravida 40 plus 3. So you know the weeks of gestation. Second thing is she has been on continuous CTG. The reason is meconium stain liquor. So we have one more risk factor there. And how are you going to interpret the CTG? First thing, we are going to look at the baseline 175, definitely elevated, reduced variability for more than 40 minutes. Again, it's abnormal. And there is late deceleration, which is there almost for past 25 minutes. If you look at the blood sample, again, it is 7.18. So it is not in the normal range. It's in the acidotic range. So what are we going to do for this baby? Are we going to offer her continuous CTG? Well, she's already been on a long gap, on a long follow-up where you see the CTG is not doing good. Second thing, are we going to give a maternal repositioning and an IV fluids? Probably that's not going to help her. Expedite delivery by category 1 cesarean section. Yes, definitely this can be chosen as one of the options. Let us look at the other options we have. Reduced oxytocin infusion and reassess. There is no mention of oxytocin infusion. It is mentioned that she is just in active labor. Next, perform artificial rupture of membranes and reassess. We already know it is meconium stain liquor, so there is no role of DNE. So the most possible explanation that can be taken as the next step here is going to be, we are going to expedite delivery by category 1 cesarean section. And the reason behind that is we have classified the CTG as pathological. Tachycardia, reduced variability, and late decelerations. Fetal blood sample again less than 7.2. It is fetal acidosis. Now, how are we going to categorize the CTG? For the EPCOG examinations, we have to remember the FIGO guidelines are taken as the classification. However, there's a very close association between the FIGO and the CTG classification by NICE. I have given you both the classifications here. The basic idea between all of this classification is to ensure that the fetus is not being compromised for a long state. To identify whether there's a fetal compromise at the earliest, we have the CTG classification. The baseline, the variability, and the deceleration, these are the three important factors that we have to keep in mind. 110 to 160 is taken as normal, variability of 5 to 25, and no repetitive decelerations. So as per FIGO, we have normal, suspicious, and pathological. For normal, we do not do any kind of intervention. For suspicious, if there is a reversible cause, then we'll have to look into that and try to correct that. But for pathological, we need to take an immediate corrective action. Now, when we look at the NICE guidelines, let us see what the NICE guidelines has for us. The CTG of the NICE guidelines, we have white, amber, and red. Again, this is based on the baseline fetal heart rate and the variability and deceleration. So always the factors that are taken into consideration are the same. And we classify them as normal, suspicious, and pathological. Again, normal means we're not going to do anything extra. We're just going to continue the management. If it is amber, that means there is some kind of risk there. And we'll have to look at a proper reassessment and see if there are any avoidable or correctable causes of this abnormal CTG. And finally, we have the pathological where we have to do an immediate intervention. So this is the basic difference that we see between the CTG of NICE and CTG of FIGO. So going into the next question, we have a 35-year-old multiparous woman who is presenting to us at 39 and 5 weeks, and she's in her second stage of labor. She's been pushing for 45 minutes and there is fetal bradycardia of 90 beats per minute, which is lasting for 3 minutes. Head is at +2, occipito posterior, cervix is completely dilated. What are we going to do here? Well, what we understand is there is a prolonged bradycardia and she needs immediate delivery. So we have to see how are we going to deliver. When you look at the options, is it going to be a ventouse, a rotational forceps, elective cesarean, category 1 cesarean, or is it a non-rotational forceps? Now, cesarean section or this is going to be an assisted vaginal delivery. There comes the difference. Definitely not an elective because she's in second stage of labor. So we have either category 1 cesarean section or a vacuum or a forceps. Now, let us look into the condition that is being posed. Multiparous, yes, there is a very good chance that she can deliver by a rotational, she can deliver by an operative vaginal delivery, let it be rotational forceps or a vacuum. Now, let us see whether she needs a rotation here. If you see the head is at +2 station, again, it's a very good indicator that both ventos and a forceps can be used. Thirdly, it is in occipital posterior position. Yes, so if the baby's head is at occipital posterior position, the baby can deliver as a face to pubis, or it will need a 180-degree rotation to bring it to occipital anterior and then deliver the baby. Cervix is fully dilated, then again the criteria of an operative vaginal delivery is fulfilled. So since the criteria of an operative delivery is fulfilled and we have a multiparous woman, we have factors that can help us deliver the baby, we'll have to choose, is it going to be a rotational forceps, ventos, or are we going to offer the women a category 1 cesarean? Now, we are choosing here a rotational forceps delivery. Why are we doing that? Because prolonged deceleration means, yes, it is definitely a fetal compromise. +2 station, occipital posterior, so rotation is necessary to bring it occipital anterior and deliver the baby out. So rotational forceps, that is Killian's forceps, will allow us for correction of OP position and it will allow us to have an effective delivery. Ventos, usually OP position we do not use because of very, very high failure rates. Category 1 cesarean section. Now, when do we choose category 1 cesarean? When you know that the delivery is not going to be imminent, then you can go in for a category 1 cesarean section. That means when you have the criteria of an operative vaginal delivery not being fulfilled, then that is the time you go and choose for it category 1 cesarean section. In this particular condition, if it is given the head is at +1 or say +2 station with an occipital anterior, then you can go in for a forceps or a vacuum. Again, looking at the difference between a forceps and a vacuum, there is a high success rate with forceps delivery compared to over vacuum delivery. So whenever you have the head very low below, though both the options can be chosen, vacuum and forceps, there is no difference between which is superior over the other. But we'll have to look at all the parameters together to come to a conclusion. We know that forceps is more complex compared to a vacuum delivery. Vacuum is more simpler. But when you have conditions like, prolonged caput is there, or molding is there, then those are the chances where your vacuum is going to be a failure. So we will have to pick up points which will give us an idea whether it is going to be a successful vacuum or will forceps be ideal in this position. And we'll have to compare the pros and cons of both vacuum and forceps, and only then we are going to choose between the both. Whenever you're talking about rotational, then you think it is only forceps. We have only rotational forceps delivery. And when delivery is not imminent or the woman is not fulfilling the criteria for an operative vaginal delivery, that is the time you go and choose for a category 1 cesarean section. So this is about assisted vaginal delivery. First thing we have to see whether we are going to do the delivery in the labor ward or we are going to consider a trial in theatre. Second thing, we have to look at the instrument, whether the operator is, having a competency with using the instrument, let it be ventos or let it be forceps. Then next thing, you have to use the instrument which is least likely to fall. Least likely to fall means for the given situation, what is the success with the vacuum, what is the success with the forceps. So that is the one criteria which is going to allow us to choose the ideal instrument in the given scenario. And if the birth is for a preterm less than 32 weeks, then avoid using vacuum. You can use vacuum between 32 to 36 weeks, but with caution. Next is application of the instrument. Next, attempt. How many attempts can you use? And when are you going to allow for a traction and when are you going to allow for a rotation? Now, rotation, usually if it is not achievable with a forceps, then you have to call in for your senior obstetrician to help. Next, how many times can you pull? If for a vacuum, we have to discontinue the vacuum if there are 2 pop-ups with the instrument. But whereas when you go for the forceps, you have to reassess if the woman is not going to deliver even after 3 successive pulls. Okay, and in the pulls, we see if there is any progressive descent of the baby. When there is no descent of the head, then again it is suggesting that it is going to be a failed instrumental delivery. So these are the important points that we have to keep in mind. Going on with the next question, we have a 30-year-old woman who is dichorionic diamniotic twins, and she is presenting at 37 weeks and 2 days in active labor. The first one is cephalic, second one is transverse. The cervix is 8 centimeter dilated. What are you going to do with her? The both are doing fine. The twin one is cephalic. Are we going to continue spontaneous labor with vaginal delivery? Plan an immediate cesarean, ECV for twin 2, elective forceps delivery for twin 1, or delay delivery until twin 2 spontaneously moves to cephalic. The woman is doing fine. There's no need of doing an immediate cesarean section. Delivery for twin 2. The twin 2 is, since it is transverse, what are we going to do? Does twin 1 need a forceps, or can we allow the twin 1 to deliver normally? These are the other parameters that we need to keep in mind. Twin 2, whether it is going into cephalic, or are we going to wait till to move into cephalic, or are we going to do any maneuvers to rotate it? These are the options given. So in this condition, I will go and choose continuous spontaneous labor with vaginal delivery attempt. Why? Because you need to deliver the twin 1, and only then you're going to think about the twin 2. So if it is DCDA twins and the first one is cephalic, just allow the cephalic delivery to happen. And for the twin 2, what are we going to do? We are going to do an internal podalic version. If not possible, you can also go in for a breech extraction. CS cesarean section is not required at this junction because the labor is going on fine. The fetal conditions and the metal conditions are fine. Then there is no emergency to rush in for a immediate cesarean section because it is again a dichorionic diamniotic twin. Next question, we have a 32-year-old gravida to para 1 with monochorionic diamniotic twins. So the twinning has changed here and she's presenting to us at 36 weeks and 3 days in spontaneous labor. First is breech, second is cephalic. And when you're doing the assessment, you find that the umbilical cord is palpable in the vagina. What is the next best step? Are we going to elevate the presenting part and do a category 1 cesarean section? Firm fundal pressure, and are we going to do a vaginal delivery? Are we going to attempt immediate breech extraction, continue labor with heart rate monitoring, or are we going to replace the cord and reassess in 30 minutes? So here is a case of palpable cord. That means what? It is a case of cord prolapse. So since it's a case of cord prolapse, we need to immediately elevate the presenting part and go in for a category 1 cesarean section. So cord prolapse is again one of the indications for doing category 1 cesarean section. Going on with the next question, we have a 38-year-old woman with gestational diabetes and she is undergoing an assisted vacuum delivery for prolonged second stage at 40+1. After the fetal head is delivered, there's no spontaneous restitution or further descent. So what are we dealing with? We are dealing with a case of shoulder dystocia. Shoulder dystocia, what is the next best step? Of course, it is going to be performing a Mech-Roberts maneuver and applying a suprapubic pressure. So these are the only two maneuvers which can be used simultaneously. That means Mech-Roberts and suprapubic pressure. So I go and choose option A, where I'm going to perform a Mech-Roberts and apply direct suprapubic pressure. Now, going on to the next scenario. Here we have a 29-year-old woman with monochorionic diamniotic twins and she's presenting to us at 35 weeks. And what is the diagnosis here? It is a case of suspected twin-twin transfusion syndrome. Twin 1 is got oliguria and abnormal CTG. Twin 2 is polyuric with severe polyhydramnios. What are we going to do for them? Expectant monitoring, amnio reduction, immediate delivery by cesarean section, give steroids, and are we going to attempt an intrauterine fetal transfusion? So this is twin-twin transfusion syndrome. Second thing is we only have the changes in the liquor. That is, one is oliguria, other one is polyuria and polyhydramnios. So for such a condition, whenever you have a monochorionic twins with a complication, with an abnormal CTG, that means the one of the fetus is compromised. So we have to do an immediate delivery with a cesarean section. So that is going to be the most appropriate answer here. Coming on to the next question. We have a 25-year-old woman in her first pregnancy. She is undergoing vacuum-assisted delivery and the indication for this is prolonged second stage at 41+1 weeks. After 3 pulls, the head is still as at +1 with no descent. So what next can you do? Are you going to continue your vacuum delivery with additional pulls? Remember, she's already 3 pulls has happened. Are you going to do a rotational forceps or are you going to do a trial of forceps? Or are you going to do a category 2 cesarean section here? Or are you going to give maternal oxytocin and continue pushing? So we have various options here of vacuum, forceps, cesarean, and expectant management. So what are the key points we have to take in mind here? Whenever there is three pulls, sequential use of instrument is generally not advised because it has a very high risk of both fetal and maternal morbidity and mortality. And we are not going to do any expectant management. Why? Because we have already given an attempt of operative vaginal delivery. So the right answer here is going to be a category 2 cesarean section. Category 2 cesarean section will be decided if the fetal conditions are good. Category 1 will be decided when the fetal is completely compromised. Next, we have a 30-year-old primary gravida who's presenting to us at 32 weeks and 4 days, and she has preterm labor. She is on continuous CTG, and the CTG shows a baseline of 155, variability of less than 5 beats per minute for 35 minutes. No accelerations, no deceleration. She's 6 centimeter. Now, what are you going to do with her? Are you going to offer her a continuous CTG and reassessment, expedite by category 1, or are you going to do a fetal scalpel sampling, give oxygen and position change, or are you going to give tocolytics? So what are the important things you have to keep in mind? 6 centimeters, preterm labor, heart rate is 155. Okay, it is variability. Yes, it is a bit on the lower side. It is less than 5 beats per minute for 35 minutes. Now, why are we offering her the woman a fetal scalp blood sampling here? Because the CTG right now, it is suspicious. The use of fetal scalp blood sampling is not very clear in labor. There are few international bodies which says do not use fetal scalp blood sampling. Few have not added any further comments on the existing rules of fetal scalp blood sampling. Okay, so whenever you have something abnormal, performing fetal scalp blood sampling will definitely help us understand if the fetus is in hypoxic state, whether an immediate delivery is needed, or are we going to wait and watch. All this will be decided based on your fetal scalp blood sampling. So here we have a 29-year-old woman who is 36 weeks and 5 days, dichorionic diamniotic twins in second stage of labor. First twin is delivered cephalic, but second is breech at station 0. Fetal heart rate is normal. What are you going to do? Are you going to do a cesarean here? Definitely no, because the heart rate is fine. Because just because it's breech, it's not necessary to do a cesarean section. Are we going to attempt an ACV here? Are we going to do a breech extraction, vacuum, or allow for spontaneous cephalic repositioning? Not required. The breech can still deliver as a breech. External cephalic version is usually not indicated here. Category 1 cesarean section, breech extraction, or are we going to apply vacuum? So if you look at the contraindications in this particular scenario, cesarean section definitely not required. ECV is usually contraindicated because very high risk of cord prolapse. Cesarean section, why do you have to do when you can still give an attempt of vaginal delivery? So the option of doing breech extraction is very much ideal. If not, the other one will be an assisted breech delivery. Going on to the next question, we have a 30-year-old primary gravida who's presenting to us at 40 weeks and 5 days, and she's undergoing vacuum assisted delivery because of prolonged second stage. After 2 pulls, the head comes to +3 station, but it is not delivered. And FHS suddenly, see if you see it, drops to 50 beats per minute for 5 minutes. So what are we going to do? Whatever is given as a background scenario, here it's a case of fetal compromise. Okay, so fetal compromise, 40 weeks, 5 days, and it was already had a vacuum delivery. What are we going to do? Are we going to give another attempt with the forceps or vacuum? With vacuum instead of vacuum, are we going to switch over to forceps? Category 1 cesarean section, do an episiotomy and attempt a rotational forceps delivery. So in this condition, we are going to offer her a category 1 cesarean section. Why? Because of prolonged fetal bradycardia. If you go back to the scenario and see, one important point that we have to notice, heart rate has dropped to 80 beats per minute for 5 minutes. So this is a case of acute fetal bradycardia, which necessitates a very, very immediate delivery. So we are going to do a category 1 cesarean section. Now, because of this fetal distress, we are not going to offer the woman vacuum because it's already a failed vacuum. So sequential instruments, we are not going to use here. Next, we have some EMQs to discuss, and let us do the cover test to understand the EMQs. We have a scenario here. We have Mrs. Sophia, 32 years, gravida to para 1 with DCDA twins at 37 weeks and 4 days. She is coming in active labor. Twin 1 is cephalic +2. Twin 2 is again longitudinal and cephalic. She had a spontaneous rupture of membranes with clear liquid before 3 hours. If you look at the twin 1, the CTG says baseline is 135, normal. Variability is normal, accelerations are present, and but there are reduced late decelerations for 20 minutes. So this is one of the factors to keep in mind. If you look at twin 2, what are the ones happening here? The basal heart line is already 160, which is more for a term pregnancy. But yes, 37.4, you can still consider that to be okay. The variability is reduced. That means it is less than 5 beats per minute for 40 minutes, and there is prolonged bradycardia at 80 beats per minute for 4 minutes. So, what are the important points here? In both the conditions, if you see, there is a deceleration that is taking place. She's 8 centimeter dilated. Contractions are good, 4 in 10 contractions, and she's already received epidural. What is the most appropriate next step? If you see, because of the prolonged deceleration in twin 2, that means that the baby is severely compromised here. For severely compromised baby, we are going to do an immediate cesarean section. So because expected management may just going to delay the delivery process, and it can worsen the condition of both the mother and the fetus, and hence the decision of category 1 cesarean section will be taken here. Next scenario, we have Miss Aisha, who's 34 years, granted 3-parotome MCDA twins, that is monochorionic diamniotic, and she is today 36 weeks and 2 days. And she is presenting to us in second stage of labor. Twin 1 delivered vaginally before 10 minutes. Twin 2 is initially cephalic. Now it is in complete breech presentation. Heart rate is doing fine. The uterus is contracted, but the cervix is fully dilated. What is your obstetrician going to assist for? Okay, is your obstetrician going to do here a vaginal delivery, or is your obstetrician here going to do a cesarean section, or are we going to do an expectant kind of management for them? Okay, so we are just going to do a breech extraction of twin 2. Why is it? Because twin 1 was, since twin 2, which was initially cephalic, is converted into breech, and the breech extraction is still appropriate for her. It is a second stage of labor, completely dilated. Yes, you can go ahead here. Now, ECV is generally contraindicated, especially after the twin 1 is delivered, because it's a very, very high risk of the baby having cord prolapse. Cesarean section is unnecessary in this condition, and vaginal delivery is usually considered safe in this condition. We have next scenario, we have Miss Emily, who is a 32-year-old, gravida 1 para 0 with monochorionic diamniotic twins at 38 weeks. She's been pushing for almost 45 minutes. Twin 1 had a ventouse-assisted vaginal delivery. Twin 2 delivered normally. But after the head has come out, the head remains tightly retracted against the perineum, which is a turtle sign. What is the most appropriate next step in this? Okay, so one thing is she has bled a lot. She will definitely require anemia and blood transfusion for maternal resuscitative measures. But most importantly, we have here a baby who's got shoulder dystocia. So the appropriate step will be using McRoberts maneuver and suprapubic pressure. Because these two maneuvers together can almost deliver 80 to 90% of cases of shoulder dystocia. Now, let us again look into some scenarios involving EMQ for us. So here we have a scenario. We have Sarah, a 32-year-old priming, who's presenting to us at 40 weeks and 2 days. She's been in the second stage for 2.5 hours. Okay, so we have a cutoff of maximum 3 hours. So 2.5 hours is still fine, despite effective maternal efforts. She has been pushing for 45 minutes with no significant descent. On vaginal examination, head is at +2, persistent occipito posterior, which is confirmed by an ultrasound also. Cervix is completely dilated, CTG is suspicious. Temperature is 37.5, but she is completely exhausted. The estimated fetal weight is 3.2 and the pelvis is normal. There is no cephalopelvic disproportion. Given the fetal malposition, that means occipito posterior and a prolonged second stage, what are we going to do? Persistent occipito posterior, what is your choice of instrument? It is going to be a Keelan's forceps delivery, where we are going to rotate the occipito posterior into occipito anterior and deliver the baby here. Second one, we have Hassan, a 29-year-old G2P1, who's presenting to us at 39 weeks and 5 days. She's been admitted with spontaneous labor. She progressed quite well in first stage, but second stage, it has been more than 2 hours since she's having very, very strong contractions. A vacuum-assisted delivery was attempted, but because the mother was already exhausted, there was concerns about the fetal distress also. After 2 pills with the vacuum cup, fetal head still remained at station +3, and there is no significant descent. So +3, 2 pulls of vacuum already done. Suddenly, if you see the heart rate is dropping to 75 beats per minute and it is remaining the same bradycardia for 5 minutes. So there is no evidence of umbilical cord prolapse because that's the most common thing that is also known there. So what are we going to do here? Again, though the scenario is quite big, a lot of information has been given. The most important one to pick up here is 75 beats per minute, bradycardia for 5 minutes. So we are going to choose a category 1 cesarean section for her. Next, we have Emily, who's a 38-year-old multi with gestational diabetes, and she's at 40 weeks, 3 days in active labor. She's been pushing for 60 minutes. So, multipara pushing, that means active second stage for 1 hour is over. Estimated fetal weight is 4.2. Now, because of exhaustion, she undergoes an instrumental delivery using a non-rotational forceps and the head is successfully delivered, but there is no restitution or further descent of the shoulder and the head is tightly retracted. That means what? We are seeing shoulder dystocia here. The CTG before delivery showed recurrent late decelerations. And because of all this, the neonatal have already requested to be on table just near you, just in case the baby requires any resuscitation. Now, what happens? Shoulders are impacted, and whatever additional efforts you're taking, you need to definitely do it properly to deliver the baby out. So, what is the most appropriate next step in this? Okay, shoulder dystocia because it can be post forceps delivery, it can be post normal delivery, whatever is the condition it is arising. First step you always do is to go in for a MEC Roberts maneuver. Along with MEC Roberts maneuver, of course, you can use suprapubic pressure also because both together combinedly it gives a all 90% resolution in most of the cases. Episiotomy is not going to resolve the dystocia, and this thing, funnel pressure is definitely a contraindicated in this condition. Zavinali maneuver is considered as one of the last methods when something has to be done to protect the baby. That's going to be Zavinali method. Now, going on with some more classifications or conditions where we're going to look at the intrapartum fetal monitoring. We have Mrs. Maria, who's a 28-year-old primey, and she's at 41 weeks, 2 days. So definitely post dates, but she's in active labor with management options for with ruptured membranes for 18 hours. Now, she's been on continuous CTG and there is meconium stained like her. CTG is showing a baseline of 175, variability of less than 5, decelerations are present, contractions is again 4 in 10 minutes. Fetal scalpel shows a pH of 7.19, lactate is again elevated 5.2, and maternal temperature is 38.1 and the WBC count is 18,000. CRP is 45. So what are the key information we get from here? We have a woman with ruptured membranes with signs of sepsis. The most important cause of sepsis here is going to be chorioamnitis. So this is going to be an emergency category 1 cesarean section. Why? Because the ETG is again abnormal, meconium stained liquor and signs of maternal infection suggest chorioamnitis. Chorioamnitis is again going to give us a very difficult scenario to deal, especially in the postpartum period. So in the antepartum period itself, we take the woman under high risk and we try to give her a care in the ICU and give her antibiotics. Now, most of the times the pH will be less than 7.2 and the lactate is going to be more than 4.8. If it is less than 7.2 and this lactate is more than 4.8, that means we are dealing with a case of fetal distress which requires immediate delivery. We have one more scenario here. We have Priya, who's 35 years old, G2P1 at 39 plus 5 weeks. She's in the second stage of labor and she's been pushing for 60 minutes. CTG shows a basal fetal line heart rate of 145, moderate variability, and early decelerations that coincide with contractions. Completely dilated head is at +3, occipito anterior, and she's been diagnosed with gestational diabetes. Now, what are the important things we have to keep in mind? Second stage, 60 minutes, already pushing is done. CTG, how are you going to classify this CTG? Baseline 145, yes, it is okay. It is just showing moderate variability. It is still fine. And early decelerations. Usually early decelerations are because of head compressions and they're usually considered not a pathological one. So we are going to do an immediate operative vaginal delivery here. Why? Your CTG is fine. She's completely dilated +3 station and diabetes. That means very high chance of shoulder dystocia. And most importantly, she came in for second stage, but it was a very, very prolonged second stage, which has been more than 60 minutes. Okay. Since all these factors are kept in mind, we need to advise a woman for an operative vaginal delivery. The next scenario, we have Sarah, who's a 40-year-old who's gravid 3 para 2, and she has been in labor for 8 hours. Labor is being augmented with oxytocin. CTG is showing a baseline of 165, variability of 10. Deceleration is variable with shoulders, contraction is 6 and 10. She's got severe abdominal pain even in between contractions. Second point, it is at -2 despite strong contractions. BP is 160, heart rate is 120. That means what? She's definitely got tachycardia, and the uterus is tense and tender on palpation. So what are we going to do here? We are going to offer her an emergency. So IV antibiotics will be given to this baby as we are suspicion as the baby has a clinical suspicion of neonatal sepsis. Going on to the next scenario. We have Leo, who's a 41-week-old term baby born via vacuum-assisted vaginal delivery due to prolonged second stage of labor. At birth, the baby is not breathing, no respiratory effort, heart rate is 40. So it is definitely less than 60 here. Resuscitation team has already provided tactile stimulation, suctioning, 30 seconds of effective positive pressure ventilation with 21% oxygen. That means with room air, but the heart rate is still less than 60. So what is the next thing we are going to do? Even after giving a PPV, if the heart rate is less than 60, that is an indication of starting immediate chest compressions. A newborn whose heart rate is less than 60 despite 30 seconds of adequate PPV requires chest compression, and the ratio is going to be 3:1. So this completes this session or the module postpartum problems. I hope this will certainly improve your preparation for the upcoming EPCOG examinations. Do follow our YouTube channel for more such videos and stay updated. All the very best for your upcoming EPCOG Part 1 exams.